Cool. Well, thanks for joining us. So before we do checking in on the landscape analysis and checking in on our, sort of 2024 plans, thinking about our work as a network and some of the research, outreach, and advocacy that we are doing and planning. Like I said in my email, at our in-person summit, our annual gathering where we vote on our policy priorities, food as medicine was again voted on as one of our top priorities. And folks explicitly asked for more examples, speakers, and cross-pollination with states that have applied for an 1115 waiver, which is one of the advocacy routes that we have discussed for how food as medicine programs can be funded. So Erika, I'll let you introduce yourself, but Erika's done a lot of great work in this field. The folks at Chilpy have been offering assistance to organizations like ours for many years, but have definitely appreciated y'all jumping on and answering random emails from our group as we move forward in this work. So I'll let you introduce yourself, and then, love to hear a little bit about some of the work you've been doing to support folks who have applied for 1115 waivers.
Sure thing. Thanks, Tyler, and thanks to everyone for having me here. My name is Erika Hanson. I'm a clinical instructor and attorney at the Center for Health Law and Policy Innovation of Harvard Law School, or Chilpy for short, as Tyler said. I appreciated all of your ways of staying warm. I do all of that. I have my tea all the time, even in the summer. I like to stay warm and I will not say that I have access to this all the time, but if I can ever find a sauna, I will jump in there. I just love saunas. Probably it's like a once a year thing, but it's my favorite thing to do. So as Tyler said, we work kind of across the nation in various different states who are looking to reform the health and food systems and advance food as medicine and health-related social needs generally. I lead our state work, and recently there's been a lot of momentum around 1115 waivers, and we can kind of talk about why that's happening. And so Tyler asked me here today to kind of talk about the national landscape, and I understand next month that you're going to have one of my colleagues from Massachusetts kind of dig a little bit deeper about what Massachusetts has done. So I actually put together just a couple of slides too, and I can share these with Tyler afterwards so you all can have these as a resource, because I think it's helpful to kind of see some of these things in graphic form. So you might be a little sick of having a lot of slides. I'm sorry, but if that's okay for me to just share these with you. Are you all seeing my PowerPoint okay?
Yep.
All right. Okay, so I'll go through these quickly. So to just kind of level set why we have to talk about these waivers and 1115, right, of the Social Security Act, as Tyler said, kind of a bad name, is just because there's no current coverage of food as medicine services. So the direct provision of food beyond really limited circumstances in our baseline Medicaid program or original Medicare under federal law. So we have to use these legal and regulatory flexibilities, such as these state waivers, right, which are named after actually the section of the law in which they live. That's why they have those bad names. And like I said, the reason why we're talking about this and why I have so much work to do in the food as medicine space right now is just because these policies really have major support from the federal government right now. And so I know you all were involved in September 2022 in the Biden-Harris administration's national conference and strategy on hunger, nutrition, and health. This strategy actually explicitly endorsed the use of 1115 waivers for food as medicine, and CMS committed to putting out guidance that would help states who are interested in doing this. In December 2022, CMS released this framework in the middle here. that would help states who wanted to put forward these successful 1115 proposals. And then just in November, on November 16th, CMS released further guidance detailing these coverage pathways for health-related social needs, including food as medicine. CHOPE is going to be putting on a webinar on December 12th, digging more deeply into this new guidance. And we'll have someone from a CBO and someone from a plan kind of talking about the potential implications of this guidance. I can drop that information into the chat later if you're interested in registering for that webinar. I'll also kind of go over this guidance. So why that's important is because these waivers, as we'll talk about, can kind of take a long time to get approval. And what the federal government is doing here is putting out these guidelines and frameworks for states so that they can move through that process faster, saying like, this is how you get a waiver approved. These are the guidelines for states to follow. So it's really important for states to be familiar with this guidance and these guidelines. So a nice overview here of kind of what Medicaid Section 1115 demonstration waivers are, how they can target patients. So just as a reminder, these are experimental demonstration projects that allow states to cover services, populations, right? They're really broad that may not be normally allowed to be covered under federal Medicaid law, right? So that's why they're so important, because things like food, housing, we normally can't do that in Medicaid, but these waivers allow that.
Erika, oh, sorry. And if I can just to butt in quickly with some Kentucky context. For folks who have been involved in Medicaid over the years here, you may have heard 1115 used in different contexts. For instance, our previous governor, Governor Bevin, applied for an 1115 waiver to build work requirements and work reporting requirements into our Medicaid program. So, 1115, like Erika said, is very broad, and we're talking about food as medicine and these supports. But if you were to search like Medicaid 1115, you would find a number of things. So
exactly, they can do tons of things, some good, right? Like food as medicine, some not so good, right? Like work requirements. So that broadness, that flexibility can kind of go both ways. And a lot of states use 1115 waivers to kind of craft their Medicaid programs and adjust it to their state's needs. So there are a lot of requirements with that flexibility that CMS imposes. So one of the things is that they must be budget neutral, but there's flexibility for the state when it comes to health-related social needs. That budget neutral or cost neutrality requirement actually doesn't apply for health-related social needs services. So it doesn't apply for food as medicine services, which is a really great plus for the states. They're not permanent changes to the Medicaid program. They have to be renewed every 3 to 5 years. And we'll kind of get into that with why that's important for the process. Health-related social need costs are capped for the state. So that includes food as medicine. They're limited to only 3% of your annual Medicaid spend in the state. That's actually a lot when you think about how much states spend on Medicaid. And there's infrastructure funding available. That's huge for Section 1115 waivers. That's the only pathway where you have this funding available. So that's things like the state's plans in your state's CBOs and other stakeholders can pay for things like technology, development of business or operational practices, workforce development, so actually paying for people to implement programs, outreach, education, and stakeholder convening. So this all facilitates kind of the delivery of services. That's also capped at 15% of that health-related social needs spending. These are the broadest possible delivery pathways. They can be statewide. They can also be just regional, right? So like North Carolina's waiver, for instance, their first proposal only targeted 3 regions in the state. They have to be medically appropriate for the individuals that are receiving services, and the states kind of set those clinical and risk factors. So some example populations that have been targeted for nutrition services by various states include individuals with chronic diet-related conditions, so things like diabetes, HIV, and AIDS, pregnant and postpartum individuals, people with serious mental illness and substance use disorder, and any of the above conditions with different social risk factors, so like risk of homelessness or food insecurity. So states have kind of picked and chose their different clinical and social risk factors from this list, right? So they can tailor to what their concerns are in their states, how broad they want their services to be, right? So a state like Massachusetts has targeted all of these populations. Other states might decide that they are really concerned about homelessness and serious mental illness and substance use, and so only target those populations. So like I mentioned, there's new federal guidance that came out in November that dictated what services can be allowed under Section 1115 for nutrition and housing. In nutrition, the services allowed include case management, nutrition counseling, home delivered meals or pantry stocking, nutrition prescriptions. So that's pretty broad. That includes like fruit and vegetable prescriptions, protein boxes, food pharmacies, and healthy food vouchers. These are the words that they use, and grocery provisions for high-risk individuals. There was some really important clarifications in this guidance. So additional support can be permitted for the household of a child identified as high risk or pregnant individuals for up to 2 months postpartum. So that's adopting a policy from Massachusetts' current waiver. And the services can be provided for up to 6 months and then renewed for an additional 6 months periods if the state determines that the beneficiary is still meeting those eligibility criteria. That's a huge change from previous guidelines from the federal government. Previously, it was 6 months, and that was the cutoff point with no renewal. And then finally,
I was just sorry, that is deeply good news. I have not had a chance to read the full guidance yet, and I know this has been a big issue when we've talked to folks out in the field. Is there a cap on the number of 6-month renewals, or is it as long as they meet clinical criteria?
From what we can tell, there is just as long as they meet clinical criteria.
Oh, that's great.
Yeah. So yeah, very exciting there. And most of these were like hidden in footnotes, very interesting in a table. So very big policy changes and wins in this guidance. And then very important note that CMS has been emphasizing that these services don't supplant, they work with complementing existing social services, such as those provided by HUD and SNAP. And there are requirements in these waivers that Medicaid work with other agencies like HUD, like SNAP, like WIC, in order to make sure that all individuals eligible for those other benefits are enrolled and receiving those services. So states really have been taking advantage of these federal policies to advance Medicaid coverage of food as medicine services on the ground. So currently we have 7 states that have been approved for food as medicine 1115 waivers. And some of these waivers might be broader, right, and cover other health-related social needs as well. So we have Arkansas that covers nutrition education only, but they have requested or they have approved a really robust waiver that includes infrastructure funds. The other 6 approved states are California, Massachusetts, North Carolina, New Jersey, Oregon, and Washington. And And those states all vary in terms of the services that they cover and the populations that they target. Then there's 4 pending states. We have Delaware, Illinois, New Mexico, and New York. Illinois is the most recent proposal. Illinois is also the broadest proposal. So in response to kind of broad public outcry, we'll say, advocacy in their state comment period, Illinois kind of radically changed their proposal to incorporate the broadest spectrum of food as medicine services and also the most expansive policies. So they now include the full spectrum of food as medicine services, as well as those household level supports that we talked about from Massachusetts. And they proposed 12 months of coverage when previously, if you remember, we had that 6-month limit. That's not a problem anymore, but that is just proof of Illinois, that advocacy at that state comment level was really important. Also, last legislative session, we had 6 states who had bills that would direct their state Medicaid agency to submit 1115 waivers to cover food as medicine services. So that's another way that states are kind of pushing these 1115 waivers. None of those bills passed, but that's a persuasion tactic.
Erika, sorry, I keep butting in, but
totally fine.
And also I did want to remind folks, do the same thing that I'm doing. And if you have a question, feel free to add it in the chat.
Definitely.
Or we can make this more conversational. A quick question on the last map, and maybe you don't have this off the top of your head, but of the folks who submitted food as medicine 1115s, do you know how many included housing supports?
Yeah, so these are not like all of the ones that include housing supports. Right, there's some that include just housing and not food, but several of these do include housing supports. So of the approved ones, we have Arkansas, California, Massachusetts, North Carolina, Oregon, and Washington all include housing supports. So that's 6 of the 7. Of the pending, I'm not sure if Delaware includes housing. I would have to double check. Illinois, I'm not sure if New Mexico does, and New York do. So I know at least 2 of the 4 do. I'm not sure if Delaware and New Mexico do. I would have to check.
Great, thanks. And I just asked that question. It's something that's come up in our group. Obviously, we're focused on the food side of this equation. And from focus groups that we've done research and outreach, housing and lack of housing has been something that's consistently come up. So yeah, just interested in the possibilities or the efficacy of those. So sorry.
They're often paired together, right? So in all of those, not to make you all sick here, going back, in all of these 2 guidances here that I mentioned, they address both housing and food. So these health-related social needs guidances that CMS is pushing, those are the 2 interventions that CMS is allowing under these waivers, and they often are paired together. Okay, so in terms of the process, so a lot of this process is dictated by statute or regulation, and then there is some state dependence, right? So the states can take more time, and there is like a little bit of leeway in terms of how states do things and how CMS does things. But generally, there's kind of these 4 stages. So we have the pre-application stage, and during this stage, states have different pre-approval processes. So some states require legislative involvement, other states do not. But generally, states need to develop an initial waiver concept. And in that, they generally convene stakeholders, draft an initial waiver demonstration in accordance with the guidelines from CMS. And sometimes states move really quickly with this, right? Sometimes just months, sometimes years, right, in crafting a really robust proposal. Then we move into state public notice and comment, and this is mandated by statute and regulation. So in this period, this needs to be at least 30 days before submission. There has to be 2 public hearings, 20 days public prior to submission, and there needs to be tribal consultation. So this is the period that I mentioned in which Illinois, for example, released their proposal. In their proposal on the food as medicine side, there was very few food as medicine interventions included, right? And that's where there was really a huge public advocacy push from the community to submit comments, to talk to the Department of Health and say, we need a much broader and more comprehensive view of food as medicine, right? And these are all of the reasons. And the state has to, in their proposal to CMS, respond to each and every comment and say, we included this, we didn't include this, and here's why. And in their response, in Illinois' response to these public comments, they said, we had this huge public response saying we need this full spectrum of food as medicine interventions, we need household level support, all of these things, and we decided to change. So this state public comment period is really important. Then the state has to submit their proposal to CMS, to the federal government, and there's a 30-day comment period there where constituents can submit comments to CMS saying, like, CMS, this is what you need to consider when you are negotiating with the state and deciding whether or not to approve it. Now, this is the longest part of the process. So this is currently taking like 15 to 24 months for approval. And during that time, CMS is reviewing the proposal, engaging with the state, and kind of negotiating and changing things. And this is why kind of staying within those guidelines and that guidance is really important for the state, because if they stray too much, there's going to be a lot to negotiate. Finally, CMS approves or rejects the waiver and releases the special terms and conditions, which are the really final terms of the waiver. But there's going to be a lot missing from there, right? It's not dictating all of the ways in which the waiver is actually going to work. So in this 4th stage, implementation and evaluation, the state is developing implementation guidance, like actually telling folks, CBOs, this is how you're actually going to deliver services. Plans, this is how you're actually going to get paid and pay CBOs, right? And so we have a lot of guidance documents that actually delve deeper into that. The state also has to submit an evaluation design to CMS within 30 days of CMS waiver approval, and then the state has to submit annual evaluation reports to CMS. Then renewal is required after 3 to 5 years, right? And that's where CMS is going to decide, like, was this actually successful, and should we let the state do this again, should the state decide they want to. This is my last slide, I promise. I know I'm going over a lot. So typically, states choose to change their waivers at renewal time, right? So at that 3 to 5 year mark. That's not the only time you have to. Like, states can propose amendments, propose new waivers anytime they want. But I'll just flag that Kentucky's next 1115 renewal is coming up in September 2024. There is an extension pending from 2022 that CMS is negotiating with the state, and the state has submitted 2 amendments. So the state really is not following kind of the common pattern of like only amending at renewal time. Like, they're just submitting amendments. So they submitted one in 2020 regarding incarcerated numbers in 2023, regarding serious mental illness. And I'm sure you all were involved in the serious mental illness amendments. It includes some referrals for health-related social needs services, including food insecurity, to the community. There's no actual like payment for that, right? It's just like referring those individuals. And I know a lot of folks, when I was looking through the comments, commented on that, like, referral is great, but often insufficient. So it's good to look to see like when it's expiring, it seems, in Kentucky, but also it seems like the state's open to just like submitting amendments kind of whenever. But that's a good thing to check, because most states often stick to that schedule.
So do amendments have to be closely related to the original 1115 plan? Okay, so this kind of would give us a potentially shorter time frame than if we were starting from scratch, is my understanding.
Yeah, so amendments don't have to be related at all. So a great example, I'm sorry, I keep bringing up Illinois, but they're a really great example. Their original 1115 waiver was about just behavioral health, very narrow. And then the amendment that they're proposing right now during their renewal process is very broad, affecting their entire Medicaid population, a very broad health-related social needs waiver that addresses food insecurity, housing insecurity, as well as they're doing like a violence prevention in their health-related social needs waiver. So it can just be kind of anything the states wants to address. Like, I don't know what you all may know what prompted Kentucky to do the incarceration 2020 amendment or the SMI 2023 amendment, but it just seems like when the state wanted to do it, and so they did it. So at any time they can do an amendment, and at renewal they can do whatever they want to do.
Yeah, and I'll just add, I'm happy to circulate some of the opportunities to engage in the SMI, the serious mental illness. There's some town halls, there's ways to engage in that process right now. But, I do know that both of those amendments were 100% advocacy. It was just folks putting pressure on the cabinet saying, you need to do this, you've waited too long, and we're not, like, you can't wait any longer.
Yeah, and there'll be evaluations that come out of those too, right? And that might be like really valuable evidence to start to grow upon, right, for this group and what you're trying to do here, which is awesome that that's already started.
Great, awesome. Yeah, that was a lot of great information. And even though I've heard some of it, it's good to be repeated because it can be a little complicated sometimes. But do folks have any specific questions for Erika or any of the stuff that we just went over?
I have a question. So I know you a few slides back you showed the map of the states that have approval and pending. So does the state as a whole have to apply, and then once approved, like whoever is seeking to do one of those waivers, that they have the ability to I guess leverage some of that funding? Or is it kind of like on a individual program basis, or how does that work? And if it is the state as a whole, then would it be like the state Medicaid office, or who would be applying for that?
Yeah, so the state Medicaid agency is in charge of making these decisions of who applies, right? And if you remember in that first stage, the pre-application process, every state's process differs a little bit. So in some states, right, the governor has to be involved. In other states, the legislature has to be involved. So you have to investigate a little bit in your state. But ultimately, it's the Medicaid agency. They make that decision. And the waiver can be crafted like a little bit differently. Like I said, in North Carolina, right, they just targeted 3 regions initially, but most tend to be statewide pilots. And then once it's approved in terms of like who gets involved, that's also determined by the state at the, waiver design process. But kind of what's happened is, like CBOs, right, can either apply like through kind of a credentialing process to start to deliver services and apply for funds, right? And through those infrastructure funds that the states have applied for through these waivers. And how the states have distributed those have differed, but most states put out like an RFP, like a request for proposals, right? And so as a CBO, you would just like apply and say, this is what I want to do with funds, right? In order to deliver these services under the waivers. And then those funds have been competitively awarded under an RFP process. So that's how it's worked in most states for deciding like who gets to be involved, and then who kind of gets funds. And then you need to work with like a health plan, right? Kind of like if you imagine how like a cardiologist works with a health plan to get their patients, right, and deliver their services.
Thank you.
And I see Rosie's comment in the chat, and definitely like SNAP Ed programs are getting really involved in these waivers. For instance, I think I've given like 7 presentations in New York who they're expecting an approval soon to SNAP Ed, groups and coalitions because their services that aren't covered by SNAP Ed may be able to be covered under the waiver, right? And kind of blending and braiding those funds, right? And also kind of working with other programs like produce prescription programs for nutrition education, right? And working together. So for sure.